Hi there, I'm Abby. I'm with LTV Capital. We invest in people building businesses powered by visual technology. We thrive on collaborating with really early stage teams that leverage computer vision, machine learning, and artificial intelligence in order to analyze visual data. This is our series, Women Leading Visual Tech. The purpose of the series is to highlight some of the top ladies whose work in visual technologies are revolutionizing business and society. We hope that by bringing together entrepreneurs, investors, technologists, and researchers in visual tech, that we cultivate a community of women and underrepresented genders who are looking to help each other succeed in the field of visual tech. In this interview, I had the pleasure of chatting with Dr. Elaine Wan. Dr. Wan is the Esther Aboodi Associate Professor of Medicine in Cardiology and Cardiac Electrophysiology at Columbia University Medical Center, College of Physicians and Surgeons. She is also an attending physician at York-Presbyterian Hospital. Dr. Wan is trained in internal medicine, clinical cardiology, and is an invasive cardiac electrophysiologist. She's a director of electrophysiology research, and she oversees all electrophysiology clinical trials. Dr. Wan is a physician scientist, and she focuses on the development of novel treatments for heart failure, vascular dysfunction, and arrhythmias, such as arterial fibrillation. She's a translational researcher, also interested in the development of innovative imaging modalities to improve ablation delivery. Dr. Wan is a graduate of MIT. She received her medical degree from Columbia University and completed her fellowship in cardiovascular diseases and clinical cardiac electrophysiology at York-Presbyterian. Dr. Wan is a recipient of numerous national and international awards, including the 2016 American College of Cardiology Young Investigator Award, first place in molecular cellular cardiology, the 2016 Young Physician Investigator Award from the American Society of Clinical Investigators, as well as the 2016 Cardiostim Europace Best Young EP presentation in Nice, France. And she was also the 2008 American Heart Association Women in Cardiology for Clinical Excellence. I really enjoyed this conversation where we talk a little bit about the moniker, "A picture is worth 1,000 words," and how that specifically implies even when you're taking pictures of something like your heart. According to Dr. Wan, 3D and even 4D images of your heart are going to play a major role in revolutionizing medicine to make it more personalized and to make treatment better overall. I hope that you enjoy this conversation and let us know what you think. Hi, Elaine. Thank you so much for joining me today.
Hi, Abby. Thank you so much for the invitation. I'm really happy to be here to chat with you.
Yeah, absolutely. I'm so excited to learn more about what you do as a cardiac electrophysiologist, because I don't think I've ever met anybody with the title before, but I know that it's one of many hats that you wear, including a hat of mom. And one of the ways that I kind of start out all of these conversations is by asking you to describe what you do to a 2-year-old or to your kid. How do you tell them what mom does during the day at work?
Yeah, I think I'm going to learn how to do that pretty soon with my toddler growing up. So my name is Elaine Wan. I'm a cardiologist. I'm also a physician scientist, so I see patients and I also do research in basic science as well as clinical science. And just to describe what I am, so I'm an associate professor at Columbia University. And if you think of the heart as a house has many parts, right? There's electrical and there's plumbing. And so plumbing is if there's a problem with the pipes or clog, then you have an interventional cardiologist who opens up the clog to fix the pipe, right? And if there's something wrong with the electricity of the house, you call an electrician. And that's exactly what I am. I'm an electrician for the heart. And how do you fix the electricity? Well, either there's a short in the system, so you have to fix the short in the electrical circuit, or sometimes the wiring is broken and you need to put a new wire and a new way to connect electrical systems. So I do both of those things.
Fascinating. I love that. I mean, I assume that growing up, you when people asked you, you weren't like, I would like to be an invasive cardiac electrophysiologist. What did you want to be when you grew up? Did you always want to be a doctor? And what was it about medicine that drew you in?
Yeah, I was always fascinated by science. And to be honest, in my younger years, I wanted to be like a cardiothoracic surgeon, like Dr. Mehmet Oz or Ben Carson, growing up reading their stories about how they use their hands to fix things. And there's something very gratifying about using your hands to directly fix someone or something. And I quickly realized that the field of cardiology and medicine was moving towards more minimally invasive, like using catheters and wires to reach the heart to fix things. So I pursued a career in interventional cardiology, specifically for the electricity of the heart. And I'm very glad that I did, because that's definitely where we are currently and continuing to grow.
That's fantastic. And so, you know, this idea of bringing together the imaging side of the world and imaging modalities, deep tech, like the machine learning, computer vision that goes into it, and heart health. You know, when did you start down this path of leveraging imaging modalities to provide more personalized therapy or care for patients with heart issues?
Yeah, I think that's a great question. I think in medical school, right, we learn about how patients are different in different ways. For example, women and men, obviously the physiology is different, different sizes, different racial differences, and physiological difference that come with that. And so we can't treat everyone's heart the same way. So definitely we have to look at the patient's the heart itself. So one way to do that is through imaging, right? For example, something imaging that we're probably all familiar with is chest x-rays, right? We do chest x-rays on people when they have a cough or a lung disease, just individualized treatment for them. So one way that we do that for the heart, well, there's several ways, are either when we look at the electricity of the heart is an EKG, and probably most people have had that, where you have electrodes on your chest, 12 of them, and it measures the electrical signal of the heart. And when you look at the imaging of the structure of the heart, there's different ways, right? You can use an ultrasound or a CAT scan or MRI. And I'm just going to pull a model of the heart just to show you. So the heart is a 3D object, right? So there's many, many curvatures. So when you look at only a 2D slice of it, you're really missing a lot of information about the curvature of the heart, the structural abnormalities like the thickness of the tissue, the size of the organ itself. So I think we definitely need to personalize our treatment for our patients by using imaging to, one, look at the biological process within each patient, and also to help risk stratify them to figure out individual treatment for these patients. And then lastly, to follow the progress of the treatment to see how they're doing over time, whether or not they're responsive or not. So I think the inspiration behind this is to really deliver personalized treatment to each patient.
That's great. And it's so interesting that you talk about it, like, because there's lots of different ways that have been mainstream for a long time, like as you mentioned, EKGs or X-rays. Why do you think it's only now that things like CAT scans and some of and MRIs are some of the ways in which we're thinking about the future of getting a 3D picture of the heart?
Yeah, well, I think it's really thanks to all that advances in technology. One is computer sciences and also machine learning, because we can imagine that there's a lot of data. So even chest X-ray, it's just a 2D image of 3D body, right? And that's already just black and white, really, when you look at an X-ray. Now we're looking at different colors, different structures, and different cross sections with higher resolution. So it's really hard to combine all that data. And that's why there's all these new modalities which are coming out, like machine learning, deep neural network learning, to try to put that all together, because there's just so much data and so much information. So I think the advent of all of that, advances in technology to synthesize the data and also to capture the data, has really allowed us to propel all of this science even further.
That makes a lot of sense. Can you give me an example of something? Because you mentioned like thickness, for example, is something that could never be told before with the existing types of heart diagnostics that were out there. Could you give me an example of like how there's something that's picked up on a 3D image really impacts diagnosis and treatment compared to what exists today?
Yeah, so definitely we have in the world of interventional cardiology, there's so many new ways of imaging. Now we don't even think of 3D, but we think of 4D. And what 4D is looking at velocity over time. So a 3D image is just an image at one time. And we want to, and as you know, the heart is an organ that keeps on pumping, filling, and contracting over time. And we want to see the movement of the heart over time. So now there's even 4D imaging. So there's a lot of advances in that. So examples of where 3D and 4D imaging is used right now, for example, is valves. So if you think of a valve as sort of like a valve in a pipe, if the valve is leaky, you want to see how much it leaks over time through contraction and relaxation of the heart. So in 3D, you can see that where the leakage actually is. And in 4D, over time, what is the velocity of the leakage and what area? Something that I mentioned over before, like you talked about, is thickness of the tissue. So when you really do a cross section through the heart, where are the thin areas, where are the thick areas? For example, athletes, they might develop a thickened heart wall because they've been exercising so much. So we want to measure that over time, the thickness of the heart tissue. So all of that can be done using 3D reconstruction of images or even cross-sectional images of the heart. So all of those are very important things that we're now looking into, and we'll continue to look into different velocities and time, thickness, tissue structure. Yeah.
That's really fascinating that even, 3D and 4D are really kind of pushing the box in terms of non-invasive ways to view inside the body and specifically the heart. And I saw that you've done a bunch of work on taking 2D video and analyzing it via deep learning in order to get some of like the same insights out of it that you might be able to through other scanning mechanisms. Do you think that, I guess the question kind of comes down to, do you think that we do need to have so many different new types of modalities to look at it? Or do you think that algorithmically you can solve for it, given what the current monitoring mechanisms are today?
I definitely think that having more dimensions adds more data and definitely adds more value for our patients. Because when you're talking about the heart, you want to be as precise as possible, right? Like sizing of a valve, or when we put like a wire, like a pacemaker through the heart, we want to be very accurate where it's going. Or when we're doing an ablation of the heart, we really only want to burn the tissue, which is like the short in the electrical system, like really just treat the area that's causing the problem. So I think being as precise as possible is really important for us. If you think of the heart, it's actually really the size of your fist. So it's really not too big. So you definitely don't want to be like a bull in a china shop and just burn or treat all the areas, just only the areas that need to be treated. So I think definitely having more refined imaging is very helpful.
Fascinating. Yeah, I mean, precision sounds great to me as a potential patient one day, right? But talking a little bit about like pacemakers and these things, I know that we've talked before about remote sensing and remote devices for patient monitoring. I was wondering, what you think about what's customary today, like the pacemaker, for example, and what do you think is really going to replace it as we move forward? 10 years from now, a patient who's at risk of heart failure, what kind of devices or techniques do you think doctors are going to be using in order to monitor them remotely?
Yeah, I think digital health has really been propelled forward by the COVID-19 pandemic, right? And now with all the technologies, it's very convenient to use, your Apple Watch, your Fitbit, or your smartphone to send an array of data to your physicians about your heart rate, your electrocardiogram, how many hours of activity that you've exercised, et cetera. So, and a lot of new devices, wearables, have been marketed to consumers to help them check what's going on. So now it's gone beyond just like a scale and your weight, right? So there's definitely now more and more wearables that can either be just put on your skin, like attached that way through an adhesive or a strap, or they're even implantable devices. For example, there are loop recorders that go underneath the skin, and they constantly track data, and they have a very huge battery life, and they can give real-time data to your physicians and also record data for yourself about whether or not you have any heart arrhythmias. That was the most common, but now the technology has advanced that it can tell you information like how many hours have you slept, what was your heart rate variability, what was the angle in which you slept, did you use a lot of pillows to sleep at night because you were very short of breath and that you might be at risk for a heart failure episode. So there's definitely a lot of data that's coming out of all these wearables. I think consumers have so many choices, and I think the key here is there's such a data deluge. Like, what do we do with all this data? And for physicians, definitely, my patients will either email me or message me either their EKGs or what their watch says, and it's really hard to keep up all of that. So I think the ways to tackle that is one, definitely having all of these resources and this data being put into some sort of electronic medical record that can be shared with all your doctors. It's not uncommon for patients to have 4 to 5 doctors if they have multiple medical problems, right? And then lastly is have some sort of machine learning algorithm that would flag the really important things to highlight. For example, like in a clinical arrhythmia, like atrial fibrillation would be really important for me to know because the patient would be at risk for stroke. But if it's just an extra beat or a skip beat, it's really that's very common in a benign arrhythmia. It can be a benign arrhythmia. So in order for me to really prioritize which patients I should really hone in to take more time to explain to them what's going on and take care of them would be really important. So yeah, very excited about the future and really looking forward to new technologies to help physicians and patients work together with all of this digital health data.
Absolutely. And it sounds like, hopefully in 5 years down the road, not even 10, that there'll be ways of taking this data and leveraging it as you look at the images in order to not only see what's going on, but then have understanding about like how it's gotten to that point or how it's improved or worsened over time, given all of the data from in between that you've gathered about the way that the patient's living their life.
Yeah, I think we're all very visual creatures, obviously, like a picture is worth 1,000 words, right? So have people look at their heart to understand, look, because of your high blood pressure, your heart is thickened to this route. And now you've made these changes or these medications, and look now, you've had a lot of benefit, and now it's back to normal, and the thickness is less. And I think that would allow us as their doctors and scientists to measure in a way comprehensively the effects of drugs or therapies, and also for patients to understand what's going on with their own bodies. So I definitely agree with you and all the other people that we interviewed before that imaging is a very important part of our future life.
That's great. Yeah, I had never thought of, a picture is worth 1,000 words before in the case of your heart, but it makes total sense that like, instead of just saying, well, how do you feel? It's saying like, hey, actually, I can show you a picture of your heart and showcase that like you're feeling better because, or you're feeling worse because, and this treatment's really working in order to keep people motivated and working towards becoming healthier as a whole.
Yeah. I
That's
mean,
great.
a very simple example is like weight loss, right?
Yeah.
People look in the mirror and they say, oh, look, I lost weight, I look better, right? But you don't really see what's going on inside your body, which is difficult. So I hope this allows not only as doctors to help deliver better care, but also for patients to understand what's going on with their own health.
Fascinating. I saw a lot of your research at the moment, of course, is focused around COVID-19 and the impact of COVID on hearts. What is the biggest takeaway from your research so far that people should really know?
Yeah, well, definitely COVID-19 in New York City, we were like the epicenter when we had the first wave, and it was really a big shock to us at that time, not knowing what to expect. And also, even right now, a lot of us had the post-traumatic stress of seeing patients who were young and old who got so sick so quickly. And at that time when we were shut down and taking turns working on the ward service, we did all our best to try to learn about the disease, right? That's what our way of trying to be proactive to help. I have 2 articles that were published in Nature Medicine. One, which was about the acute effects of what we saw, the multi-organs, the systemic disorder of COVID-19. And then the next article we published in Nature Medicine was about long COVID, about the remaining, the post-acute, long-lasting effects that we saw. So one of the things as the heart doctor we saw was that COVID was causing both a plumbing and electrical issues. So we had patients that had acute clot development in their blood vessels that caused a heart attack. And then we saw patients who suddenly either had heart block, that means the conduction system was not working and they needed a pacemaker, or they suddenly went into cardiac arrest because they had a short in their electrical system and they went into the dangerous arrhythmia of ventricular tachycardia or ventricular fibrillation. So we really saw a wide array of different arrhythmias. What was definitely the most common was atrial fibrillation. In normal days, atrial fibrillation is a very common arrhythmia, but when patients had full-on systemic inflammation and had other comorbidities brought about by COVID, we saw more and more patients with atrial fibrillation. And we showed in one of our articles that if you had COVID and you had atrial fibrillation with some sort of myocardial injury, you were definitely at a higher risk of having complications in the hospital and a higher risk of death with COVID. And I think the great news is that there's been, thanks to the advance of science, we had the RNA vaccinations available. And now, in the most recent Omicron surge, most people really only have a mild case. We didn't see any of the myocardial inflammation and disastrous deleterious effects of COVID that we saw in the first wave. But I think it was very important for us to document it because we were sort of one of the first cities to see that, and that we could share with our colleagues to look, to be aware and cautious that this is what they might see in their patients as the virus sort of spread throughout the nation. But that was sort of the motivation behind all of that.
Yeah, absolutely. Well, I mean, it's such great news that we're seeing, much less of the high risk cases today than we were at the beginning, and that doctors are prepared and are looking out for those kinds of things. I saw, and I think there was like a paper published maybe over the past couple of days that was taking images of the lungs, and it was showcasing you images of the lungs. And I wasn't sure, should we be expecting, or are there any things out there that are like showcasing pictures of the heart as impacted by COVID?
Yeah, I think like we talked about just now, the chest x-ray is very easy to do, right? It's just like there's radiation involved, unfortunately, but it's just like a black and white picture, and it's very easy to do. The cost is very low. And for imaging of the heart, there's difficulties in that, for example, an MRI, which can be built together to give information about the heart in 3 dimensions, is time consuming and it's costly. So I think the key is to have more ways of developing non-invasive but 3D imaging of the heart that we can use to personalize treatment and also personalized imaging for patients.
Yeah, absolutely. And I guess maybe one group where this comes into effect in a major way, you've also done some work into looking at the disparities in the healthcare system, particularly on the misclassification of sudden cardiac death and then out of hospital sudden death for women and people of color. And so, I mean, if I read between the lines, this idea of imaging and getting a better idea to personalize the healthcare of each individual, do you think that that's going to play a major role in overcoming some of these disparities and major, I don't want to call them major failings of the healthcare system, but failings of our healthcare system today because they've been treating everybody exactly the same?
Yeah, so I mean, it's a really complex question because one has to be availability of the technology and, most importantly, access to the technology, right?
Yeah.
So I think I think the COVID pandemic has highlighted that these are ongoing issues that are difficult to answer in a short period of time. But definitely if there was more access, widely available technology, then hopefully that could allow us to personalize treatment and monitoring of healthcare for different patients. I think that one is we need to solve more simple problems first, of like testing and blood tests, et cetera, before we do to even more complex things like complex imaging. But ultimately, yes, what we knew, which is a mission from the last decade and now, is genetics, right? Understanding the genetic buildup of each person. Now we know what your genes are, but what is being expressed and what's not, and what's actually going in your body now. So I think imaging is helpful for that, because sometimes you might have the genes, but doesn't mean that it's being expressed or turned on. So the answer is, what is being turned on? What is it being turned on? And what has some intervention affected what's going on right now? So I think you bring up the great examples of, we've had chest x-ray for the lungs and CT scans for the lung. We definitely want to advance imaging for the heart, and specifically for things such as cardiac arrhythmias, because it's definitely a very common diagnosis to have atrial fibrillation, or people with palpitations, feeling skip beats. What is going on with their heart that might cause them to feel this or have this?
Yeah, absolutely. All right, so I'm gonna change pace just a little bit here and ask you, I suspect, and I'd love your perspective on how the cardiology world is for women who are looking to enter into it today. Like, what was it when you entered like the cardiology space? How did you feel like it was actually supporting women and supporting growth of women within the space? And how do you think it's changed over the past, few years?
Yeah, I definitely think there's been progress, and I'm extremely thankful for my colleagues here who are very supportive. Currently, I'm the only women faculty in the cardiac electrophysiology field, but I'm happy to share that we hired a second woman, which is great. I'm extremely supportive of it. And our program is one of the most proactive about recruiting women. So currently we have 3 female fellows as electrophysiologists, and we've graduated at least 5 or 6, and they've gone on to become independent women managing their own laboratories. So I think that our field is here in our institution at Columbia EP is very supportive of women. Overall, when I first started my cardiology fellowship, definitely women were not in anywhere near the halfway mark. I think there were only 2 of us, and the rest of my class were men. But once again, all my male colleagues were very supportive. They always treated me as an equal, taking call or taking care of sick patients, seeing how I could how they could help me if I were in a very, very busy day or a lot of critically ill patients. So I think I was very lucky that a very supportive environment. And I think now the initiative at Columbia to really provide inclusivity and a sense of belonging for all comers, healthcare providers and students of different race, gender, or sexual orientation, I think is a great sense of inclusivity. And I think that's very important, because that reflects the providers that can provide care to patients, right? And our patients are very diverse. And it's only through having these different providers that they could advocate for these patients and advocate, for example, that clinical trials should, like physicians, should have diversity and should have an equal mix of women and men, and a diversity in who they recruit and who practices it. And I think that's definitely one major way of counteracting all the disparities that we see. I definitely think you and I are both women, and you interview all the women in science, and there are a lot of things that we don't share or are afraid to share, right? So one, for example, is the peripartum period, the postpartum period, and then transitioning back to work. Those are really difficult times. I can tell you, like, I'm an academic physician scientist, and this time raising a young family is probably, especially in the setting of the COVID pandemic, is the most difficult time I've ever had in my career. One is in the peripartum period, if you're lucky, you really don't have that many symptoms, right? Or you might have, hyperemesis gravidarum where you feel constantly sick, which is morning sickness, right? If you have that all the time. And then the postpartum period, you have to struggle with if your infant is sleeping well or not, and breastfeeding and lactation, which is definitely tough for us who were wearing heavy lead all the time, right?
Yeah.
So you're feeling constricted, you don't have time to pump or make sure that your child has the nutrition that you want to provide him or her, right? And then it's the transition back from maternity leave where you're devoting all your time to your infant, your child, and then suddenly it's like an on-off switch where you suddenly just have to go back to work. There's no in between for some jobs, especially jobs where you have to be on site and you're not working remotely. And you and I just mentioned before we started this conversation, COVID pandemic has been really hard about daycare, being on quarantine. All of us, I think, have been on some sort of daycare or school quarantine, because any URI, you're already flagged. And children, being sick is what they're all about when they're all together. And then if you're lucky, you don't get sick with them. But if you're sick, everyone's sick, and then you still have to do your job. So it's another full-time job. And not that I don't think that I feel like we're making advances, but I think there are a lot of other things that can be done to be helpful. Definitely for women in science, tenure track is a very difficult thing to achieve, maintaining productivity, getting grants and writing papers, and being a mom is definitely a full-time job. And you don't want to feel like you're sacrificing being a mother or wife or a daughter for attaining your career goals. So I look forward to women working together to be more proactive, to advocate for each other. That I'm a big proponent of women supporting each other. I'm so glad that's one of the ways I got to where I was, is having great female mentors. And I think what's a good thing is having women in leadership roles to promote these needs. If you don't have women in a position to advocate for these needs, then the rest of us will never have a speaking or a time to talk about what we need to allow us to have success.
For sure. I second everything that you mentioned. One of the big things that we talk about in Venture is about how, women fund women at much larger proportions than men do. And women, help women. And there's so many issues and there's things to talk about, like even talking about the sheer fact that, like, hey, coming back from maternity leave and trying to find somewhere to pump in between back to back patient visits and things like this are just issues that, as supportive as men are, they don't necessarily have. And so having an advocate for you at the upper echelons of your university or your practice or your firm just becomes such an important part of furthering women in the workforce as a whole. Well, I really appreciate you taking the time to chat and sharing so many of your amazing insights. I love, all of this idea that by getting a better image of our heart and seeing it in 3D, that in 4D even, that it's really going to help healthcare become more personalized, more predictive, right? And better, healthier people overall. So I so appreciate you taking the time to share the insights and look forward to talking to you again soon.
Yeah, thank you so much. I really enjoyed talking to everyone and to you, personally about this. Hopefully the next time we meet, there are more new technologies to share.
Yeah, absolutely. Thank you.